Good afternoon and good morning, and welcome to the workshop Graft-versus-Host Disease, How It Affects Your Skin. My name is Jordan Sexton, and I'll be your moderator for this workshop. Before we begin, I'd like to thank Incyte Corporation, whose support helped make this workshop possible. It's now my pleasure to introduce today's speaker, Dr. Alina Markova. Dr. Markova is an associate professor of dermatology at Weill Cornell Medical College. She is also the co-director of the multidisciplinary GVHD clinic at Memorial Sloan Kettering Cancer Center in New York City. Dr. Markova specializes in treating skin conditions that develop after a bone marrow or stem cell transplant. Her outpatient clinical practice is devoted to helping people affected by graft-versus-host disease of the skin. She also specializes in treating people who develop skin, hair, and nail conditions as a side effect of cancer treatment and people with cancerous wounds. Please join me in welcoming Dr. Markova.
Thank you so much for the kind introduction, and it's my pleasure to spend the next hour with you to review how GVHD affects the skin, hair, and nails. So I'm going to go to the next slide. So our objectives for this session are to understand the various ways that chronic graft-versus-host disease can affect the skin, hair, and nails. We're going to review the timeline of manifestations of chronic GVHD on the skin, hair, and nails. And we're going to describe how cutaneous chronic graft-versus-host disease affects activities of daily living. Lastly, we're going to summarize pharmacologic and non-pharmacologic therapies that can help patients who have cutaneous graft-versus-host disease. As some of you may know, there are two main presentations of skin GVHD. After the day of transplant, in the first approximately 100 days, a patient may develop a rash that oftentimes would be considered acute graft-versus-host disease. Later on in the course, after the transplant, a patient may develop different types of rashes and skin changes that may be considered chronic graft-versus-host disease. And while there's a typical timeline of developing acute GVHD in the first 100 days and chronic later than that, really the way we diagnose the type of rash and the type of GVHD is based on the features of the skin and not exclusively based on the timeline. So chronic graft-versus-host disease sometimes can happen before 100 days, though rarely, and acute graft-versus-host disease can occur after 100 days and not infrequently. So as I mentioned, acute GVHD presents typically in those first 100 days. It presents as a pink, flat patches and smaller areas called macules that can be raised at times. It can be itchy or it can be very minimally symptomatic. It can affect all parts of the body, and it can evolve. It can start first on the face or upper chest or arms and really progress to the rest of the body. Very rarely, acute GVHD can blister. And you can see in this patient right here, there are blisters developing, and that is typically painful. The way we determine the severity of acute GVHD is by the percentage of skin involved. So a stage 0 GVHD is 0% body surface area involved. Stage 1 of acute GVHD involves less than 25% of the body surface area. And we really only count the areas that are involved, not the areas that are spared in between the involved areas. Stage 2 acute GVHD involves 25 to 50% of the body surface area of the total skin surface, and stage 3 involves over 50%. Stage 4 really is once a patient has over 50% skin involvement and then blister formation on at least over 5%. So really rash on 50% or more and blistering with over 5% of that, and that's considered stage 4. Acute GVHD of the skin, while it oftentimes stage 1 and even some stage 2 skin GVHD can be exclusively managed with topical therapies. Later stages and more refractory stage 2 disease may require systemic therapies. Topical therapies that can be helpful are topical steroids, topical calcineurin inhibitors, and narrowband UVB phototherapy. So the top two can come as creams or different vehicles that I'll review in the next slide. The topical steroids are typically are anti-inflammatory medications that have certain side effects like skin thinning, but can be very effective. Topical calcineurin inhibitors are also anti-inflammatory without the side effects of skin thinning, but can be greasy and some patients can have a burning sensation. Phototherapy is a lovely addition that can target the whole skin, but it does require visits 3 times a week to a local dermatology practice to receive the phototherapy, which may also be associated with a copay. Topicals, when we talk about topical steroids or even topical calcineurin inhibitors, come in different vehicles. And what a vehicle is the formulation of the medication. And different formulations can be associated with different strengths of the same topical steroid. They can also have different benefits. So while solutions, sprays, gels, and foams are easy to apply, they do contain alcohol. So if there is any broken skin, these can have a burning sensation from the alcohol. Creams, oils, and ointments are greasier, and they can be very effective and soothe broken skin, but in areas where there's hair bearing, so any hairy sites, or extensive application requirements, the creams and ointments can be challenging. Certain medications like the topical calcineurin inhibitors, such as tacrolimus and pimecrolimus, are only come as creams or ointments. So not every medication is available in every vehicle, but if you prefer a certain type of vehicle, you can always ask your oncologist or your dermatologist to try to prescribe you the same topical in a different vehicle. For example, solutions and sprays are really nice to apply to the scalp. These are easier to part the hair, if there is hair, and apply to the scalp. If the hair is very dry and tightly wound, curly, oils are nice for the scalp as well. Gels and foams can also be used. And for areas such as the face, creams may be preferred. So typically for localized therapy of acute graft-versus-host disease of the skin, we start with applying topical steroids twice daily and or topical calcineurin inhibitors twice daily. Most of our treatments are really applied just twice daily. More than that can lead to additional side effects without additional benefit. If this treatment is inadequate, we can recommend narrowband ultraviolet B phototherapy, which is just like a medical tanning bed. That's a safer version, or systemic therapy as per the bone marrow transplant team. And there is an approved therapy for acute GVHD called ruxolitinib, which is a JAK1/2 inhibitor, and is taken also twice daily. If you are interested in phototherapy, the easiest way to find a phototherapy center near you, it does not have to be at your cancer center or your BMT practice, it can be somewhere closer, is to go to the American Academy of Dermatology website. And there, if you search Find a Dermatologist or just add the /FAD, you can enter your location with your zip code and city or state, and select phototherapy in the second column under procedures, and it will provide a list of local dermatologists who offer phototherapy. Another option would be to call your insurance and inquire as to which dermatologists are available who would offer phototherapy near you. And you can also find out about your copay. Some insurances do charge a copay for every phototherapy visit, and of course this can quickly add up, so you can be aware and ask that question as well, as this may impact your decision as to whether you want phototherapy. And now that I've covered acute GVHD, I'm going to move on to chronic GVHD. Chronic GVHD has two main phenotypes or presentations. One is the non-scarring variant or non-sclerotic variant, and the other is a scarring or sclerotic variant. One presentation of the non-scarring variant is called lichenoid chronic graft-versus-host disease. This presents as purplish bumps on the skin that can be red and scaly, and they can affect the back of the neck, the chest. They can have a little bit of this lacy pattern, as you can see on the neck in this patient, and they can be quite extensive. So you can see in this patient generalized purplish, whitish plaques across the hands and palms with little normal skin retained. And this can involve the lips, can appear pinkish and purplish in darker skin as well, and can be very extensive on the chest. You can see when lichen planus-like GVHD affects the distal fingers and the palms, a patient may develop white little bumps and loss of the fingertip anatomy, and that can be very sensitive and uncomfortable. And there are things we would do topically to help manage that, such as the topical therapies previously discussed for acute GVHD. So topical therapies that we offer for chronic GVHD that's non-scarring are very similar to the topical therapies for acute GVHD. We typically discuss topical steroids, topical calcineurin inhibitors, and narrowband UVB phototherapy for more generalized disease. Of course, if the topicals are inadequate, we would always discuss with our BMT colleagues to consider adding an additional line of therapy while still maintaining the topical use. An additional line of therapy that's approved for chronic GVHD includes ibrutinib, ruxolitinib, belumosudil, and most recently, axatilimab. And moving on to the scarring type of GVHD, or sclerotic GVHD. So sclerotic GVHD may present with these white plaques, oftentimes at areas of trauma. So we see these over the underarm area, over old port sites, old surgical sites, old bone marrow biopsies. These can affect areas of prior radiation. So an area that previously had radiation may have a very tight plaque there that appears with the onset of the sclerotic GVHD. Other areas that sclerotic GVHD may appear at is areas of common trauma. So when patients wear bras or pants, these can appear at the points of light, frequent trauma, so at the waistband and at the bra lines. Sclerotic GVHD, unfortunately, can progress and be quite extensive, leading to reduced range of motion without even having joint graft-versus-host disease. So patients can have extensive sclerotic plaques on their arms, on their chest, abdomen, that may limit their ability to take a deep breath or to eat a big meal or a normal-sized meal. And on the legs, these can lead to progressive tightness and then ulceration or wounds on the legs. So it is important to try to treat these with systemic therapies, as topical therapies may have limited efficacy for scarring chronic graft-versus-host disease. We often perform a photographic range of motion to assess patients and determine whether they have their tightness in the skin or joints is affecting their range of motion. And we don't make patients perform every procedure, every position. We actually just ask them to perform the rightmost ones, so the 7-7-7-4, and then we scale them and see how far they can get. And normal is expected is the 3 7s and the 4s. That's the baseline for the patient. And we monitor how they are affected by GVHD with respect to their range of motion. And then after they are started on systemic therapies, we can monitor for improvement. So this can be a very reassuring score as patients improve on systemic therapy. Wounds may develop within sclerotic GVHD, and you can see there are ulcers on the back of the foot here and on the belly, and these can be very uncomfortable and get secondarily infected, and really they develop in a setting of a scarring involvement of the skin from the GVHD, whereby the skin cannot heal and it remains with an open wound. And really to treat these wounds, in addition to good wound care, is really to treat the underlying sclerotic GVHD typically with these systemic therapies. The topical therapies for chronic scarring GVHD, the topical steroids and topical calcineurin inhibitors are typically minimally effective. The scarring in the skin is quite deep, and so we typically minimally use topicals in sclerotic GVHD or scarring GVHD. We only use topicals if a patient is having symptoms. For example, if a patient is having itch or pain or inflammation that they feel is uncomfortable, we might use a topical therapy to reduce those symptoms. But ultimately, it's not going to change the course of the GVHD without a systemic therapy. As I mentioned, wound care is paramount to reduce risk for infections, especially when patients are on immunocompromising systemic therapies for their GVHD. When there is when really there's any sclerotic GVHD, systemic therapy should be considered. And as I mentioned, the approved systemic therapies in order of approval, as may have been mentioned in other talks throughout this workshop, are ibrutinib, then belumosudil, ruxolitinib, and most recently axatilimab. Extracorporeal photopheresis is also used in both acute and chronic graft-versus-host disease, and this is where the blood is removed and exposed to something that's a sorolin, a medication that sensitizes the blood to light, and then it's reinfused into the patient in a process that allows decreased inflammation in the blood and ultimately decreased inflammation in the skin. UVA1 phototherapy is a light application, just like the other light therapy I shared, but the wavelength penetrates deeper and allows for potential improvement in sclerotic or scarring graft-versus-host disease. Stretch marks may develop with prolonged systemic steroid use, especially in children who undergo bone marrow transplant around the pubertal time. And these stretch marks can be really extensive and sometimes break down. We do offer some therapies, although it's very challenging to effectively treat stretch marks. So main ways that we treat stretch marks, so available therapies include topical tretinoin, which is a vitamin A derivative cream oftentimes used for acne. This improves early stretch marks, as you can see in the images to the right. It reduces the length and width of stretch marks. We usually start this every other night, just a very, very thin layer. And as patients tolerate this cream more, we increase to nightly. The limitations of using this therapy are that patients may experience dryness, pinkness, skin peeling with the treatment, and so we have to start slowly with this every other night application. And then we move on. We support this by adding moisturizers as well as to combat the dryness. We typically avoid using topical steroids on stretch marks because topical steroids can further thin the skin and create wounds within the stretch marks. So in areas of stretch marks, we typically discourage using topical steroids. Stretch marks may also be treated with a laser. So there are two main laser types that are used for stretch marks. One that targets the redness and the pinkness, and that's typically a pulsed dye laser, or called PDL laser. And that effectively can treat the red blood cells that are going through the little blood vessels in the stretch marks and remove the red color for those patients who are bothered by the red. This can be done depending on how extensive. Even in one treatment, a patient may experience significant improvement, but additional treatments may be necessary depending on how extensive the stretch marks are. If a patient is bothered by the texture, where the stretch marks indent in or pouch out, the available lasers oftentimes include lasers that are called fractional CO2 laser or an YAG laser. These types of lasers make microscopic holes in the skin that create a stimulus for collagen to rebuild and strengthen the skin again. So this one does have a little bit of a recovery time where the skin may have a little bit of crusting and need wound care for a week or so to recover. The pulse dye laser really can have bruising but no skin opening, so the recovery time is a little bit shorter. And CO2 laser, as you can see in this picture, can have a positive effect on even late-stage stretch marks. So in the left side of both columns here, you can see that this is after CO2 laser. The stretch marks improved after several treatments. So the one limiting factor is really lasers are rarely covered for medical purposes, so the cost of the laser treatments is oftentimes out of pocket. Microneedling is another approach for stretch marks. It can be safe and effective. In this one study, a patient with stretch marks had over 50% improvement after 2 treatments. And the main side effects are really transient pinkness. This is oftentimes less expensive than a laser treatment and an option. But again, for these, I would recommend going to a dermatologist or a plastic surgeon who is familiar with safe application of these invasive treatments. A question that oftentimes comes up is, how do you wash your skin when you have skin GVHD? And given how often patients are generally washing their hands to prevent their risk for infections, reduce their risk for infections, the guidance we typically provide is to still wash your hands to prevent infections, dry your hands with a clean towel, but leave some water in your hands, and then immediately after washing your hands, apply a fragrance-free moisturizer. When possible, we also recommend using a bar soap to wash your hands. Bar soaps have less additions that can dry out the skin. Foaming agents oftentimes can be irritating, can dry out the skin, so bar soaps really are the gentlest soaps that you can use for your hands. We encourage the same in the shower, so using a gentle, fragrance-free soap or cleanser, ideally a bar soap, and keeping the showers relatively short, although 20 minutes is quite a long shower, so less than 20 minutes, bath or shower with lukewarm water. And avoid any antibacterial soaps, in particular with triclosan, because those can take off the natural oils on the skin and further dry out the skin. All soaps are antibacterial by removing the bacteria, so you do not need to additionally have antibacterial ingredients. And another question that frequently comes up with patients is, what's the order of my skin products when I have GVHD? How do I apply all the different products I want to use? So the first is always going to be to apply your medicated cream or ointment onto the skin. And that's because you want the medication to have direct contact with the skin. After that is applied and absorbed, if it's a medicated liquid or lotion and you want an extra moisturizer, then any moisturizer you're planning to use, you can apply on top of the medicated topical. On top of that, you can add a sunscreen, and then lastly, you would do makeup. For most patients, if they are going to use both a moisturizer and a sunscreen, I strongly recommend using a moisturizer with sunscreen so you can simplify your regimen. And makeup can also actually combine the three. Many makeup nowadays have CC cream options, etc., where they basically have a moisturizer, sunscreen, and makeup combined into one. And those are oftentimes much easier to apply than having 3 separate topicals. But generally, that is the order, whether you do medicated topical, then sunscreen, then makeup, or just medicated cream and then makeup. All of those are appropriate, but always medicated first. And how do you choose a moisturizer when you have skin GVHD? So generally, we recommend choosing an ointment or a cream, so something that you scoop. Anything with a pump bottle is typically more of a lotion that can have some alcohol and cause burning on the skin, and it typically does not moisturize quite as well as an ointment or cream. We recommend applying something like petroleum jelly or another type of fragrance-free cream, moisturizing cream, that your care team may recommend when the skin is still damp. So after you get out of the shower, the best time to apply moisturizer is right when your skin is damp because it'll lock in that moisture on the skin and keep it moist. We also recommend sealing in the moisture by covering any moisturized hands and feet with cotton gloves or nitrile gloves or socks to seal in the moisture. And that can give those painful hands some additional relief. And choosing sunblocks can be challenging. There are so many options available. And so we wanted to review 2 main categories of sunscreens. One is the chemical and one is the mineral. So chemical sunscreens such as octinoxate, oxybenzone, avobenzone ingredients, you can look at the back of your sunscreen bottle, are easier to spread on the skin. They come in water-resistant options. They can work well if you do not have sensitive skin. They oftentimes work better in darker skin patients because they don't leave a white glaze on the skin, but they can cause some allergies. And so we oftentimes recommend mineral sunblocks, which have ingredients of zinc oxide or titanium dioxide. These are thicker, whiter, and they may not rub into the skin as easily. It's a better choice, however, for sensitive skin. And how do we sun protect when patients have GVHD? So we always recommend to apply sunblock 20 minutes before you go outside. Choose a broad spectrum sun protection factor of 30 and above. Wear clothing that protects your skin from the sun. While sunblock is great, nothing is better than really just not having to reapply the creams in the first place by wearing ultraviolet protective factor clothing, UPF clothing, that's available frequently at sports stores, and there are some online brands as well that offer UPF clothing. And this reduces how much sunblock you have to use. If you, for example, if a patient wears long-sleeved UPF clothing with some long skirt or long pants, the sunblock only really needs to be applied to the face, hands that are exposed, and then a wide-brimmed hat can be worn. We strongly recommend wide-brimmed hats, especially if there's hair thinning, since the scalp is no longer protected, and the scalp is a really high-risk site for skin cancer because there's very thin skin there, and so skin cancers can become aggressive on the scalp. We typically say to avoid the sun between the peak hours of the sun between 10 a.m. and 4 p.m. But we still encourage patients to go outside and enjoy their lives outside. You've survived so much going through the transplant and now living as a survivor with graft-versus-host disease, and we want you to enjoy your life outdoors, but we recommend doing it in a smart way by protecting yourself so that the risks for skin cancer and GVHD flares are minimized. Using makeup when you have skin GVHD is another question that comes up frequently, and again, social events may come up. Patients oftentimes would like to resume makeup to feel more like themselves and go back to work. And so we do recommend using fragrance-free products made for sensitive skin when possible, avoiding products that are natural or unpreserved because they may contain germs, and try one product at a time every few days. You may have new allergies, even to products you previously used. And so it's really important to have a stepwise approach to adding new products back in. It's okay to use makeup to cover a rash if the skin is not broken, and a concealer to cover any dark or light spots. There is some additional guidance about makeup, and particularly it really applies to all patients, but certainly a patients at increased risk for infections. Throw out your older products and buy new ones regularly. Replace mascaras every few months. Replace eyeshadow every year, and foundation every 1 to 2 years, and replace lipsticks and blushes every 1 to 2 years as well. You can replace these more frequently if you so choose, but at the minimum, try to replace them this way. I'm going to move on to nail changes, which is another feature of GVHD that can be quite symptomatic. Patients with GVHD may develop these ridges along the nails, as well as some lifting of the nail plate and peeling of the nails. Patients may experience complete nail loss, and this can be very uncomfortable. Sometimes the nails will snag on the clothing. So we do recommend certain things to try to improve the symptoms. First and foremost, we advise the use of nail hardeners that are over the counter. Two common brands that we recommend are Sally Hansen Hard as Nails or Nail Tech. And these really coat the nail and make it stronger, and it can be applied every night even, and facilitate kind of protecting the nail. Oral biotin may be taken daily to support hardening of the nails as well. And for significant inflammation of the nail, we do recommend applying a high-potency topical steroid. and that can be used nightly, really to the nail bed, the nail fold, so the area of where the nail is coming out of. In patients who have scarring or complete loss of the nail or approaching that, we sometimes perform steroid injections into the nail fold, which can be quite painful. So most often, if the nails are significantly affected, we really do recommend systemic therapy for GVHD to treat the nails, and the nails do improve with systemic therapy. We'll cover hair loss after transplant. So patients may have hair loss after transplant for a variety of reasons. The most common is what we call anagen effluvium. This is hair loss in the first 6 months after chemotherapy. It affects about 90% of the hair on the scalp, and it typically regrows in the several months after transplant. This will regrow on its own, but there are some things we can do to expedite the regrowth. Rarely, patients will have persistent chemotherapy-induced alopecia. So this is hair loss lasting over 6 months after the chemotherapy, and we offer certain therapies to support this. Additionally, patients may have GVHD-associated hair loss that can occur as part of chronic GVHD, and this can be scarring or non-scarring. Patients may also have hair loss from other conditions, decreased nutritional state, also thyroid changes. All of this can contribute to hair loss. So we like to evaluate patients for their thyroid function and their nutritional nutrients, so vitamins and minerals, to make sure that patients have adequate stores to support hair regrowth. And you can see in this patient, hair loss can be non-scarring. So a patient can regrow the hair, there's no scale, there's no loss of the hair follicle, or it can be scarring, where a patient loses hair follicles and the scalp becomes a little bit shinier, and hair regrowth in those areas may not be possible. It's important to know the type of hair loss the patient has, whether it's scarring or non-scarring. If there's any inflammation in the scalp, we do recommend using a topical steroid. And we typically, if there's any hair thinning, add either topical or oral minoxidil. Most patients prefer using oral minoxidil or oral Rogaine, which is a historical antihypertensive, but in the dermatology setting, it's used at very low dosages that do not typically affect blood pressure and help with hair growth by prolonging the growing phase of the hair and by thickening the hair. Another treatment that we add if the patient has no inflammation, so we won't use topical steroids, but we will use either topical or oral minoxidil. We'll use oral finasteride or oral spironolactone, and these are all available hair therapies. If there's scarring, we'll still add minoxidil to increase the density. And as long as if there's active inflammation, we would prescribe topical steroids and also discuss systemic therapy for the GVHD. But if the scarring is old and the GVHD is well controlled and essentially inactive, then we may recommend hair transplant. We also typically add a topical antifungal shampoo called ketoconazole shampoo applied to the scalp 3 times a week. And this can also thicken the hair, even when used off-label for just hair thickening and not a fungal etiology. You can see in this study, this was a study of women with breast cancer treated with minoxidil, and the minoxidil shortened the period of baldness by an average of 50 days. It does not prevent alopecia, but it can support faster regrowth. And minoxidil may help reduce the appearance of scarring GVHD by increasing the background hair density. So it cannot regrow scarred over hairs, but it can make the existing hairs thicker and reduce how thin it appears. Minoxidil takes at least 6 months to work, and really its peak effect is at 12 months, and then it plateaus and generally keeps the patient with the hair stable. May not have additional significant regrowth beyond that, but the hair loss is less than it would be if the patient was not on minoxidil. Hair care comes up often in patients who have graft-versus-host disease. We typically recommend washing and conditioning the hair every 2 to 4 days, although that may change depending on the hair type, ethnicity, and common washing and conditioning practices. the most frequent we recommend every 2 to 4 days, but it can be less frequent because the natural oils stay on the hair, and that's helpful. We recommend using a shampoo and a cream rinse or hair conditioner. And when you brush or comb your hair, start at the ends. Use a soft bristle brush, a comb, or your fingers. Use over-the-counter, as I mentioned, the antifungal shampoo for dandruff scale, and this can also increase the hair thickness. We also recommend certain powders that can camouflage the hair thinning. There are pigmented concealing powders that can be applied to the hairs. They come in different colors, and they can come as a powder, a lotion, or a spray. And you can see in the patient on the left before the powder, right after, can really fill in. They attach to the hairs themselves and or cover the scalp and can really provide fill-in of the scalp that mask the hair thinning. Hair transplantation really is only used once the GVHD is inactive. The main advantages are that it's effective and permanent, but it is performed under local anesthesia, so it does not require OR time, but there is pain associated with the numbing. There's risk for scalp swelling, bleeding, and minor infections. There's a risk of unnatural-looking hair, and there is a scar wherever the hair is removed from, and it is expensive as it is not covered by insurance. Micropigmentation is another option to create the appearance of hair follicles. This is basically a form of almost like tattooing of the scalp to recreate hair density. It's relatively permanent. It resembles pores on the scalp, but there is a small risk of infection from the procedure. Some patients may be allergic to the pigment. Natural hair must be dyed to match the pigment if it's growing in addition to the pigment that's placed, and this may need touch-ups over time. So in summary, acute graft-versus-host disease of the skin presents as a maculopapular rash, so a pink, red, scaly rash that may or may not be itchy. Chronic graft-versus-host disease may affect the skin, hair, or nails and has two main forms, scarring and non-scarring, and they require different treatments. Many treatments are available that can improve your quality of life. Notify your care team if you develop any signs or symptoms of skin, hair, or nail GVHD. And especially with telehealth and the way photos are so readily available, absolutely always document any new rashes, new skin symptoms, hair, nail symptoms with photos. Take them, send them to your provider, and ask for help. Ask for a referral if you want specialized care, but there are clinicians who can help you with these symptoms, and I strongly recommend reaching out and asking for help. And even though the skin may not seem important, or the hair may not seem important, or the nails, this is important for you to feel like yourself and maintain your quality of life. And so it is important to clinicians, and we want to help you with it. I want to thank you. That's our Memorial Sloan Kettering Cancer Center in the center. That's our outpatient building. And I am happy to take any questions. Thank you.
Wonderful.
So much.
Thank you very much, Dr. Markova. This was an excellent presentation. So we're now going to begin the question and answer session. If you have a question for Dr. Markova, please use the chat box on the left side of the screen to submit your question. And we're going to answer as many questions as possible. I think we have about 20 minutes to do so. So the first question I have for you here is from someone who says their daughter is constantly itchy and has reddish white bumps and patches since having the stem cell transplant 6 years later. What do you suggest in using to relieve the itching?
That's a really, really great question, and something I'll add in a future module. So when there are skin changes accompanied by itch, the most important is to first treat the inflammation and the redness in the skin that's causing the itch. So a patient with skin changes typically benefits from either a topical steroid or a topical calcineurin inhibitor at the very least, and that can help some of the itch symptoms. But if a patient has significant itch and the topical steroids are inadequate, and the patient is starting systemic therapy for any sort of generalized rash, we also typically add oral medications for the itch. Some patients start with medications such as just over-the-counter diphenhydramine or Benadryl, but we also can add medications such as hydroxyzine, which is another type of antihistamine that sometimes can work better for itch. And one of our favorite medications that works for itch, that works on the nerves that contribute to itch, approved for neuropathy, is pregabalin. Pregabalin is a gabapentinoid, and it can be very effective for itch. It can make patients drowsy, so we typically start at night, and then we increase the morning dose. And patients are usually take a dose twice a day. It has multiple different dosages, so the dose can be tailored for the size of the patient. Another medication we sometimes use off-label for itch is called a Prepitant, and that's used for chemo-induced nausea, but also works on the itch pathway. So there are many different medications that can help with itch, but really understanding why the patient is having itch. If it's itch with rash, really targeting the rash is the key.
Excellent. And what's the reason to apply sunscreen 20 minutes before going outside?
That's a great question. It is because it is not effective immediately, in particular with chemical sunscreens. They have to interact with your skin, whereas the mineral blockers work almost immediately. The chemical sunscreens do not.
Good deal. And for systemic therapies, can you combine pharmaceuticals like belumosudil, ruxolitinib, sirolimus, and axatilimab at the same time? If so, how would the provider determine which one is effective? Additionally, are there diagnostic tools to identify the cause or pathology of the particular type of GVHD to help determine the best treatment?
That's a great question. We are combining all of those therapies in one patient, but rarely are these added at one time. So typically a patient may be on a GVHD prophylactic therapy such as the sirolimus, and then develop GVHD. When a patient develops chronic GVHD, first-line therapy may be added, oftentimes with systemic steroids, and if a patient progresses on systemic steroids, something like ruxolitinib may be added next. And the typical ruxolitinib typically takes about 2 months to start to see a response in chronic graft-versus-host disease, somewhere from 2 to 2.5 months. And if a patient is really not improving at that time or progressing despite being on ruxolitinib and being on the full dose, typically another medication is added, and that can be the belumosudil or the axatilimab. And then if a patient has some sort of partial response to the ruxolitinib, partial response to the belumosudil, but still pretty active disease, a third agent can be added, such as axatilimab. But if a patient is on, for example, ruxolitinib for several months without improvement, then oftentimes that medication will be discontinued and the patient will be switched to a different medication in lieu of adding to minimize the polypharmacy or the total number of medications the patient has. And also some of the ways we decide which treatments to use, and really BMT is the one who's prescribing these, but is oftentimes based on what insurance may approve. Sometimes insurances have therapeutic ladders that we need to go through. And other treatments are known to work better in sclerotic or non-sclerotic GVHD. We generally know that ruxolitinib is effective for acute and both types of chronic GVHD, and belumosudil as well. And axatilimab has shown to have great improvements in sclerotic GVHD. So we try to target, but we're still learning as to which drugs work best for which type of GVHD. And then as far as the other question about diagnosis, so in chronic GVHD, a skin biopsy may be used, especially if it's non-sclerotic or non-scarring GVHD, to make sure that the patient has chronic graft-versus-host disease and not another type of rash, such as eczema or psoriasis. It's not always required. It's often not required because the GVHD is often easier to clinically diagnose. And for sclerotic GVHD or scarring GVHD, we rarely need to biopsy because it's clinically diagnostic, and GVHD is ultimately a clinical diagnosis. But if there's something in the differential, some other type of process, a biopsy may be helpful, but primarily it's in the non-scarring chronic GVHD variant.
Good deal. And you mentioned the name of a shampoo earlier. Could you please repeat the name of it and spell it if you can?
Yes, it's ketoconazole shampoo. It's this fourth bullet here on the slide. The prescription ketoconazole shampoo. It's an antifungal shampoo. I think the brand name is typically called Nizoral. and it can be applied to the scalp, and then a patient would use their own shampoo after, because this one is just a medication to the scalp, and it's lathered on for about a couple of minutes and then rinsed off, and then normal hair care is resumed.
Cool. And could GVHD of the skin be caused by any medications or certain foods? If so, can you give any examples?
There are no foods that have been associated that I'm aware of with graft-versus-host disease. For medications, treatments such as, for example, donor lymphocyte infusion can cause and flare GVHD. In certain patients who are very sensitive to immune stimulation, other immune stimuli can cause GVHD flare, so exposure to a virus, exposure to a vaccination. Sometimes if the patient is very sensitive to this, they'll notice that anytime they have a cold or an upper respiratory infection that their GVHD flares a little bit, and same thing can happen in the setting of a vaccine. But otherwise, most medications have not been associated with GVHD. Worse exacerbations, though certainly tapering or reducing GVHD immunosuppression can cause a GVHD flare.
Good deal. And do you have any advice or information about skin GVHD looking like cellulite?
Yes, absolutely. So in patients with early scarring GVHD, the GVHD may present like new areas of cellulite, relatively quickly developing, oftentimes in the inner arms or on the inner thighs, and it can feel firm and really be very quickly appearing. So unlike regular cellulite, which can develop over many months, this appears much more quickly and continues to progress. So this is a sign of sclerotic GVHD, and it really merits an evaluation by a bone marrow transplant physician and or a dermatologist.
Good deal. And do you have suggestions when chronic GVHD affects the fascia and the fingers become less flexible long term?
That's very challenging. When it's active, again, the systemic therapies for GVHD are key. We partner very closely with our physiatrists or rehab medicine doctors because they can give exercises and stretches for the fingers and for other joints that are affected by fascial graft-versus-host disease. Sometimes they even prepare splints to help stretch out the fingers. If the tightness is really largely not just from the fascia, but really from the skin tightness, we can even do CO2 laser to try to soften up that tightness and increase range of motion. So that is also done as well.
Cool. And is there anything that can be done to repair thin skin as a result of steroids?
Unfortunately, it's very challenging to repair thin skin. The approaches are largely related to using the tretinoin cream that I previously mentioned for the stretch marks, as well as CO2 laser can be used in focal areas. But the generalized thinness, it's really hard to recover. The main thing is really time and avoiding additional topical steroids.
Good deal. And what is myofascial treatment, and is it effective for skin GVHD?
So myofascial treatment is typically something that our physiatrists discuss with our patients because it's deeper to the skin. So I would defer to them on that. It's not, it doesn't target the skin itself, it targets the deeper fascia. And so I would defer to them. On the skin, it's not a skin targeting treatment. So it would not help skin GVHD, but it could help the fascial deep component of GVHD, but not the skin itself.
Cool. And will fingernails ever grow back to normal after GVHD?
That is a great question. It depends on the type of GVHD changes a patient has in their fingernails. So a patient who has splitting of the nails after chemotherapy, fingernails after that regrow in 6 months, toenails in about 1.5 to 2 years. For GVHD that's non-scarring, the nails typically regrow. They may not be as strong as they were originally, but they do regrow. When there's scarring, it depends on the extent of scarring. If there is extensive scarring and the stem cells that produce the nail, that are right where the nail fold is, are damaged, then the nail may never regrow normally.
This person was diagnosed with chemo-induced alopecia a few years after transplant, and their hair is very thin and sparse now. What do you think of shampoos, conditioners, and scalp serums like Vegamore to grow or activate more follicles in hair?
That's a great question. So if there's diffuse thinning from chemotherapy, the most effective therapies are adding something like oral minoxidil, oral spironolactone, oral finasteride, or oral dutasteride, and oftentimes a combination of therapies, as well as adding the ketoconazole shampoo and doing a nutritional workup to make sure all of your nutrients are adequate to promote hair growth, that the thyroid function is adequate. Most of the over-the-counter shampoos that are advertised are typically very expensive, but really with minimal effective ingredients, or some of the ingredients at low dosages have some minimal efficacy, but not nearly compared to the systemic therapies by mouth. So we really, when there's extensive hair thinning, we really encourage using the oral minoxidil as a starting point, and then using hair powders as well.
Okay. The next question is someone who is 4 years post-transplant and would like to be outside more. They're usually covered from head to toe due to GVHD, and they're wondering if they'll ever be able to go to the pool or the beach again.
That's really, really tough. Yes, absolutely. As I mentioned, we encourage going. You can go to the pool, you can go to the beach, but we typically would recommend wearing a rash guard, like a UPF rash guard. That's a long sleeve one. They even make swim pants and a wide brim hat. And then all that needs to be reapplied is the face and hands. And that's really the safest way. Of course, you can go to the pool or the beach at less sunny times as well. So at like start of the day or end of the day, and at that point you might not really need the swim pants. But I would still recommend wearing the long sleeve rash guard to really protect the skin. But yes, go just wear the gear. And we recommend that to not just GVHD patients. We recommend the same to patients with a history of melanoma or very fair-skinned patients who are at high risk of skin cancer. And there are many brands that make cute swimsuits and rash guards at this point, so they can be fashionable as well.
And what kind of doctor would be the one to prescribe ketoconazole shampoo? Sorry, the one you mentioned earlier. I think yeah,
ketoconazole.
Yeah, would that be a dermatologist?
Okay. It could be a dermatologist, it could be a primary care doctor, a BMT physician. It's a really low-risk medication and is oftentimes prescribed just for dandruff of the scalp. So really anyone can prescribe it.
Good deal. One person has a follow-up question with regards to oral medications. Can they be stopped? I don't know which ones in general they may be referring to, but.
So the oral, if it's related to hair, the oral medications for hair loss, if the hair loss is related to a remote insult, so whether that's GVHD that's already controlled or chemotherapy and the hair regrows to a point where the patient is happy, then they can be stopped. If the hair loss is related to hormonal changes after transplant, then if the oral medications for hair loss are stopped, the patient is likely to continue to suffer from that hormonal etiology of the hair loss and continue to have hair shedding. So in those cases, we do not typically stop and we continue. As far as if it's oral systemic therapies for GVHD, it really depends on whether the patient's GVHD is controlled, and those are tapered off very slowly.
Good deal. And I think we have 5 minutes left, so we'll be taking our last question now. But this person has become heat intolerant since their transplant, and when they wear lotion, especially cream-based ones, it feels like it's trapping heat in their body. Do you have any suggestions on what to use that lets their skin breathe while it's hydrating?
That's a challenging scenario, and many of our patients will experience either inability to sweat or sweating too much and sensitivity to their sweat, like itching, burning when they do sweat. And that oftentimes does improve over the years after transplant. There are some gel-based moisturizers, and patients can find those to be more soothing. Another one, they're called like gel creams, but they're gel-based. And then other options, some patients like, there's this Aquaphor spray, which is an emollient, but it's a petrolatum spray, but really it's like kind of cooling when you spray on like a sunblock, but it moisturizes. So that's another potential option.
Good deal. Well, thank you very much, Dr. Markova, on behalf of BMT Infonet and our partners. I think this was a fantastic and informative presentation. And thank you to the audience for your excellent questions. And please contact BMT Infonet if we can help you in any way. Thank you.